Welcome to the deep dive. Today we're tackling a really critical area, open surgical treatment for renovascular disease. We're talking about the arteries feeding your kidneys.
Exactly. And for this deep dive, we're drawing from, the gold standard Rutherford's vascular surgery and endovascular therapy, the latest 10th edition.
Right.
Our focus is really on understanding why, even now, with all the newer techniques, open surgery for these kidney arteries is still, well, really important.
Okay, renovascular disease, kidneys, arteries. It's the plumbing, basically. And the approach has really changed over time, hasn't it?
Oh, absolutely. It started way back with just, taking out the kidney nephrectomy.
Heuristic.
Yeah. Then came open surgery to try and fix the arteries, and more recently, all the excitement about endovascular stuff, balloons, stents, that kind of thing.
And the book points out that with each new thing, there was this initial burst of optimism.
Right. But then as we got more data, things got a bit more, let's say, realistic. So while endovascular is common now, what we want to unpack today is when open surgery isn't just an option, but maybe the best one.
Got it. So the mission here is to figure out when and how open surgery still makes sense for renovascular disease. Pull out the key reasons, the deciding factors for you.
Precisely. We're looking beyond the trends to see the real value of open repair for specific, carefully chosen patients.
All right, let's jump in. When do surgeons actually say, okay, we need to do open surgery here? What are the indicators?
Well, the big picture goal, always, is helping patients live longer, healthier lives, avoiding major problems like dialysis. And here's something interesting.
Yeah.
Patients who have really severe high blood pressure before the surgery, they often seem to get the most benefit from open repair.
Wait, really? Super high blood pressure is a good sign. That sounds backwards.
It does seem counterintuitive, doesn't it? But the thinking is, for those patients, fixing the blood flow can make a bigger difference. And then the key thing we look at afterwards is kidney function.
How well the kidneys are working post-op.
Exactly. If their filtering improves, that's a huge predictor of staying off dialysis long term. Dialysis-free survival, that's a major endpoint.
Okay, makes sense. Fix the artery, kidney works better, less chance of needing dialysis down the road. But the text also says it's tricky to predict exactly who will respond well.
That's a really crucial point. Even things like renin levels, the kidney hormone involved in blood pressure, they haven't turned out to be super reliable predictors for individual patients.
Huh.
Some studies looked at Doppler resistive index, trying to link that to outcomes, but those results haven't really held up consistently, especially not for open surgery.
But then the authors mentioned their own experience over 1,000 open surgeries. And they did find factors that pointed towards good kidney recovery.
Yes, and it paints a pretty specific picture. You're looking at patients with, like we said, severe hypertension beforehand, also really tight narrowings over 90%, or even complete blockages affecting both kidneys or the artery to a single kidney. And the third thing is rapidly worsening kidney function before the operation.
So bad hypertension, severe blockages, and kidneys already going downhill fast, those are the signs that open repair might actually work well.
Paradoxically, yes. And get this, for patients who are already on dialysis but had these features, a stunning 70% of them were able to permanently stop dialysis after the open repair.
70% off dialysis. That's incredible.
It really is. It shows the potential in that specific group. Now, the text also touches on, well, what if you don't intervene?
Right. The old thinking was find a blockage, fix it, because it'll just get worse.
Exactly. But a big population study looking at older folks kind of challenged that. They found that for asymptomatic disease, meaning mild to moderate narrowing, mild to moderate hypertension, no major symptoms doing prophylactic surgery wasn't actually helpful. Over about 8.5 years, very few of those patients actually progressed to a point where the blockage was hemodynamically significant or their kidneys failed.
So just finding some narrowing on a scan isn't an automatic ticket to the OR, especially if blood pressure and kidney function are reasonably okay. That's important for people to know.
Definitely. So the decision for open repair hinges on severity, location, one side, both sides, and that severe hypertension. It's almost always a prerequisite.
And if someone does have severe blockages on both sides, bad hypertension and poor kidney function,
Then doing both sides at once, bilateral revascularization, is often the plan.
but what if the kidney function is terrible, but blood pressure is only mildly high?
Then you have to think maybe something else is the main driver of the kidney problem, not just the artery narrowing. Usually when renovascular disease is the primary cause of severe kidney failure, You see that combination of severe bilateral disease and significant hypertension.
Okay. And you wouldn't do a preventative fix during, say, an aortic repair if there's no severe hypertension.
Generally, no. The recommendation is against prophylactic repair. And when they do operate, the goal is to fix all significant renal artery problems in one go, unless it's one of those complex ex vivo cases we'll get to.
And nephrectomy, removing the kidney, that's only for...
Really only if the kidney isn't working at all or if it's actively causing high blood pressure and can't be salvaged.
And the preferred technique is usually a direct aortorenal reconstruction, going from the main aorta straight to the kidney artery.
That's the preference, yeah. For a couple reasons. Often these patients also have disease in their gut arteries, like the celiac axis.
Right.
And like we said, many need repairs on both sides. Direct aortorenal repair lets the surgeon tackle both kidneys and potentially other nearby arteries more easily. Plus, you really want that first repair to be durable because a failed repair increases the risk of needing dialysis later.
Makes sense. Get it right the first time.
And they emphasize using intraoperative assessment, like ultrasound, to check the repair during the surgery.
We'll definitely come back to that. So the authors are still strong advocates for open repair in certain groups, despite the rise of endovascular.
They are. They specifically mention children with hypoplastic underdeveloped arteries, adults with dysplastic lesions, problems with the artery wall structure, except for simple medial fibroplasia.
Okay.
But if that medial fibroplasia involves branch arteries and aneurysms, then open surgery is often recommended. And then there's the group we discussed. Good risk patients, usually under 65, with critical blockages, severe hypertension, and declining kidney function.
They also briefly touch on renal artery aneurysms, preferring open repair there too, but that's another topic.
Right, covered elsewhere. And standard practice during surgery involves giving mannitol early on.
To protect the kidney.
Yeah, helps with urine output.
Yeah.
And then heparin, a blood thinner, right before they clamp the artery to prevent clots.
Okay, so that covers the when. Let's talk how. How do they actually get in there and do the surgery? Operative exposure.
Right. Depends what needs fixing. For bilateral repairs, or if they're also working on the aorta, the standard is a midline incision.
Straight down the middle of the abdomen.
Exactly. Patient on their back, maybe table flexed a bit. They extend the incision up towards the chest slightly. Release some ligaments there for better access up high near the kidney arteries. Use retractors to hold things open.
Gotcha.
Now, if it's just one side, maybe involving branch arteries, or for certain bypass types like splanchnic renal, they might use a flank incision on the side.
Okay. And with that midline approach, how do they navigate to the kidney arteries?
Carefully. They open the lining over the aorta, then gently mobilize the duodenum, the first part of the small intestine, moving it over to the right. Got to watch out for the meandering mesenteric vessel there.
For tricky.
Yeah. This exposes the left renal vein. They extend the opening up, and to the left, behind the pancreas, to see the whole left renal hilum where the artery and vein go into the kidney. The artery is usually behind the vein. They might lift the vein up or push it down, sometimes tie off smaller draining veins like the gonadal or adrenal to get a good look, especially further out along the artery. There's a lumbar vein back there too that needs care.
And the right side?
The proximal part near the aorta you can get to by going through the base of the mesentery, moving the left renal vein up and the vena cava over. But for the rest of the right artery, you usually need to mobilize the duodenine and the right side of the colon medially toward the center.
Move things out of the way.
Right. Lift the right renal vein up, and the artery is typically right behind or below it. And they mention being aware of potential accessory renal arteries lower down, sometimes crossing in front of the vena cava.
Okay, exposure achieved. Now, the actual repair techniques, you mentioned 3 main direct ones.
Yes. Aortorenal bypass, thromboendarterectomy, and reimplantation. Bypass is probably the most common, using a new vessel to get around the blockage.
Like a detour?
Exactly. Thromboendarterectomy is cleaning out the plaque from the inside of the existing artery. And reimplantation is moving the kidney artery's connection point on the aorta.
Let's break those down. Aortorenal bypass, what do they use for the new vessel?
Several options. Saphenous vein from the leg is often preferred, especially in older adults.
Yeah.
For kids, if reimplantation isn't possible, maybe the hypogastric artery from the pelvis.
Using the patient's own tissue.
Ideally, yes.
Yeah.
But synthetic grafts like PTFE or Dacron are alternatives if the vein isn't suitable, or for combined aortic procedures. If there are early branches off the kidney artery, they might shape the connection to include those.
And sewing it in.
Very carefully. The arteriotomy, the opening in the kidney artery has to be the right length, Fine sutures, often under magnification, flush out air and debris before tying the last stitch.
Okay.
If it's a quick bypass, under maybe 40 minutes, they might not need to cool the kidney. Yep. Usually, the aortic end of the bypass goes on first. If combined with an aortic graft, the renal bypass graft, often thin-walled PTFE, attaches to the aortic graft, and the kidney connection is last.
Makes sense. What about thrombonotorectomy, cleaning out the plaque? When's that used?
Often for osteal disease atherosclerosis, right at the opening of both renal arteries, especially if there are multiple arteries involved. The usual way is transaortic.
Through the aorta itself.
Yeah.
Yeah.
Long incision in the aorta, peel out the plaque lining from the aorta, and then kind of invert or turn inside out the renal artery openings to peel the plaque out of them directly. Then close the aorta.
Wow.
Or if they're replacing the aorta anyway, they can do it through the open end. The key is really mobilizing the renal arteries well so you can fully avert them and see the plaque clearly.
Any reason not to do this?
Yeah, if the aorta is weak, like preaneurysmal, or has really heavy transmural calcification, calcium going all the way through the wall, not suitable then.
Got it. And the third one, reimplantation, moving the connection.
Right. This works if the blockage is right at the origin and the artery itself is long enough. You cut the renal artery off the aorta and sew it back on slightly lower down.
Just shift it.
Pretty much. Spatulate the end, widen it, maybe remove a little button of aortic wall to make a nice wide connection. It's particularly good for kids with orifice lesions, avoids a graft, but can be used in adults too for certain plaque types. Usually done after the upper aortic connection is made, but before the lower one, if they're also doing aortic work.
Okay, those are the direct routes. What about the indirect ones mentioned splanchnic renal and hepatorenal bypass?
Yeah, those are alternatives maybe for higher risk patients where a direct aortorenal repair seems too much. But the authors state they don't think these indirect routes are quite as durable long term.
Okay. Hepatorenal bypass liver artery to kidney artery.
Basically, yes. Incision under the right ribs, expose the hepatic artery, find the right renal artery near the vena cava, usually use a saphenous vein graft. So one end to the hepatic artery.
Whereabouts?
Often where the gastroduodenal artery comes off, or maybe on the common hepatic artery itself, routing the graft behind the stomach through the foramen of Winslow. The other end gets sewn end to end onto the cut right renal artery, bringing it in front of the vena cava.
Complex plumbing. And splenorenal. Spleen artery to kidney artery.
That's the one. Midline or left subcostal incision. Mobilize the pancreas up, dissect out the splenic artery way back towards the spleen, find the left renal artery. Then you might cut the splenic artery and sew it directly end to end onto the cut left renal artery.
Without removing the spleen.
Usually, yes, splenectomy isn't needed, or alternatively, you could use a vein graft between the splenic and renal arteries.
Interesting alternatives, but maybe not as durable. Let's shift to ex vivo reconstruction. That sounds intense, operating on the kidney outside the body.
It is pretty intense. And it's becoming more necessary sometimes because endovascular techniques often handle the main artery problems, leaving these complex branch artery issues inside the kidney for open surgery. The big challenge is ischemia time. The kidney can't tolerate being without blood flow for long, maybe 40 minutes max if it's warm. So protecting it is crucial.
And the best way is cooling it down. Hypothermia.
Exactly. That's the most effective protection if you expect the ischemia to last over an hour. They use surface cooling with ice slush or hypothermic perfusion circulating cold fluid through the kidney's vessels.
What are the steps for that?
Well, start with mannitol and heparin, like other repairs.
Yeah.
The cold perfusion fluid ideally has an electrolyte balance similar to inside the cells, and usually after the repair, the kidney goes back into its original spot orthotopic placement.
Not move somewhere else.
Right. The incision is typically a longer flank incision.
Right.
Mobilize the ureter, mobilize the kidney, divide the vessels, then either pack it in ice slush or put it in a sterile bag and connect the artery to a hanging bag of cold preservative solution.
How does the perfusion work?
They hang the bag about 6 feet up, flush it through continuously or intermittently until the fluid coming out the vein is clear and the kidney looks pale. They reperfuse after each connection too, which keeps it cold and checks for leaks. Goal is core temp below 10 Celsius.
Amazing. Why not just transplant it somewhere easier, like the iliac fossa near the hip, like they do with donor kidneys?
Good question. Yeah. For transplants, that location is less invasive, easier to examine, maybe easier to remove if rejected. But those advantages don't really apply here with the patient's own kidney. Plus, many of these ex vivo patients are younger, so the repair needs to last decades. Attaching it to the iliac arteries, which might develop their own disease later, could compromise things. And having a kidney down there could complicate future leg artery surgeries.
Right.
Putting it back where it belongs, connected to a healthy aorta, aims for the same durability as a standard direct repair, hopefully lasting a lifetime.
Okay, the complex repair is done, kidneys back in. How do they check their work right then and there?
This is critical. Flawless technical repair is key for long-term success. Late blockages are rare if the initial job is perfect. And the best tool for checking, according to the text, is intraoperative duplex sonography ultrasound during surgery.
Better than angiography, injecting dye.
It has advantages, yes. Real-time imaging right there. High frequencies give amazing detail down to tiny flaws. You can scan from multiple angles with blood actually flowing. Plus, Doppler gives you hemodynamic info, how the blood is flowing before and after the repair.
And no contrast dye needed.
Exactly. Which is better for the kidneys, especially if they're already compromised. It really requires good teamwork between the surgeon and the ultrasound tech, though.
So what are they looking for with the ultrasound probe?
After filling the area with warm saline, they use the B-scan first for the visual image, looking along the artery, checking the aorta, the origins, the whole repair. If they see something odd, they check it in cross-section.
Confirm it's real.
Right. Then they use Doppler to listen and look at the flow patterns just before and just after any suspect area. They have criteria like if the peak velocity jumps way up, say over 2 meters per second, and there's turbulence downstream, that suggests a significant narrowing, probably over 60%.
And this is pretty accurate.
Their experience showed high sensitivity and specificity for picking up technical defects that could cause problems later.
Are there any tricky findings, things that look weird but are okay?
Yeah, a few things. You'll always see some spectral broadening on Doppler, even in a perfect repair, just because the sample volume is small. After a transaortic endarterectomy, the sound might be a bit oscillating. That's usually fine.
Okay.
Sometimes you see high velocities all the way along the repair without a specific jump or turbulence. If it's consistent, especially after non-atherosclerotic repairs or in a single kidney, it might not be a true stenosis. Same if velocity increases going into smaller branch vessels after a repair, as long as there's no distal turbulence.
But what about real problems? What do they look like?
On the B-scan, irregular bright stuff inside the artery could be thrombus, a clot forming. That's an emergency. Got to reopen and fix it immediately.
Right.
Even smaller things, like a little flap of artery lining loose after endarterectomy, even if flows aren't terrible, might need a revision because it could cause a dissection or blockage later. Depending on the finding, they might need to remove a clot, do more endarterectomy, or put on a patch graft to whiten the area.
So that intraoperative check sounds absolutely vital. Okay, let's talk results. After all this, how do patients actually do?
Well, the Author Center has huge experience, over 1,700 repairs in over 1,000 patients. They found that postoperative stenosis, or thrombosis, a blockage, happened in only about 3.3% of the repairs.
That seems pretty low.
It is. And recurrent hypertension or declining kidney function occurred in just under 4% of patients over about 3 years follow-up. Interestingly, even if a repair fails completely, sometimes it still helps blood pressure, almost like removing the kidney would have. Post-op ultrasounds confirmed a low rate of significant narrowing, around 3.4%.
What about complications from the surgery itself? Morbidity, mortality?
There are risks, of course. Prolonged hospital stays happened in maybe 15–20%. But needing new permanent dialysis soon after surgery was very rare, less than 0.5% for those with pre-existing kidney issues. Perioperative mortality was linked to age and poor heart function.
What were the rates?
Around 0.8% for isolated renal repairs, 1.6% for bilateral, and about 3.3% when combined with aortic surgery for atherosclerosis. Higher if gut arteries were also involved.
And the main goals, blood pressure and kidney function.
Blood pressure response was good. 85% were cured or improved 2 months out. And getting blood pressure cured was linked to better long-term survival.
That's significant.
Kidney function also improved overall. For those with ischemic nephropathy, kidney damage from poor blood flow beforehand, almost 60% improved within 3 weeks. And remember that 70% figure for dialysis patients coming off dialysis. Yeah. And they found the worse the kidney function was before surgery. In those carefully selected patients with severe hypertension and rapidly declining function, the more likely they were to see improvement after surgery.
Wow, so selection is just paramount.
Absolutely critical. Both pre-op factors like diabetes, severe aortic disease, poor kidney function, and post-op responses like blood pressure cure and kidney function improvement were tied to long-term outcomes like avoiding death or dialysis. There was a clear interaction there.
What if the open repair fails, though? What happens then?
Yeah, they looked at that too. They sometimes did repeat surgeries or nephrectomies. Unfortunately, patients whose first open repair failed had worse dialysis-free survival and a much higher risk of eventually needing dialysis, no matter what was done next.
That really underlines the need to operate for the right reasons, doesn't it?
Exactly. Operate for clear indications, severe hypertension, kidney insufficiency, not just preventatively. And it shows how durable a direct aortorenal repair can be when it's successful.
Okay. The outline mentioned a chapter algorithm, like a flowchart for decisions. Can you quickly walk us through that logic?
Sure. It basically steps the surgeon through the key questions. Where's the lesion? Proximal, mid, distal branch, or official? Is there accompanying aortic disease, atherosclerosis, or aneurysm? Is it non-atherosclerotic disease? What's the anticipated warm ischemia time?
Answering those helps choose.
Helps choose the conduit if bypass is needed, vein, synthetic hypogastric artery,
Mm.
and the specific technique, bypass, endarterectomy, reimplantation. And the very last box on the flowchart is a reminder: intraoperative duplex assessment after all repairs.
Check your work. Finally, the chapter highlights some key references. Why were those particular papers important?
They're foundational. Sharon Hansen et al. Established that improving kidney function itself is key for dialysis-free survival, not just blood pressure control.
Ah, the kidney function is primary.
Right. Zhao and Rhee's work explained the importance of the renin-angiotensin system within tissues throughout the body, beyond just the kidneys. Rimmer and Gennari summarize how atherosclerotic lesions progress and impact kidney function. And Stanley et al. Is crucial for understanding how to manage this in kids, where causes are often different.
This has been incredibly thorough, a real deep dive into open surgery for renovascular disease. It's clear it's still a very important tool.
Absolutely. The big takeaways really are: patient selection is everything. Focus on those with severe hypertension, decline in kidney function, and significant disease. Technique matters. Immensely meticulous surgery, checked with intraoperative ultrasound.
Right.
And the potential for significant renal function recovery, even getting people off dialysis, is, well, it's remarkable in the right patient group.
It really is. Which leads to a final thought for you, the listener. As both open and endovascular techniques continue to evolve and we learn more about the nuances of renovascular disease, how might things like personalized medicine or even better image tech change how we approach this? Could we get even better at picking the perfect treatment for each individual and improving those long-term outcomes? Something to think about. We definitely encourage you to look at the references if you want to learn more. Thanks for joining us for this deep dive.